If you're listening to this podcast on YouTube, for a better experience, switch to the video version. The link is in the top right corner of the video and in the episode description. Hello and welcome, I'm Fernando, a GP in the UK. Today we're reviewing the NICE guideline on hypertension in adults, always focusing on what is relevant in primary care only. In the last two episodes we covered the diagnosis and the criteria for urgent referral. Today we will focus on initial management, when to start drug treatment and how to monitor hypertension. Right, let's jump into it. And let's remember that the recommendations in the hypertension guideline apply to all adults, including those with type 2 diabetes. However, in some situations, management differs and NICE recommends referring to the other relevant guidelines, including those on chronic kidney disease, type 1 diabetes, and hypertension in pregnancy. Now let's look at lifestyle interventions. We should offer lifestyle advice and continue to reinforce this periodically. We should ask about diet and exercise patterns, because a healthy diet and regular exercise can help reduce blood pressure. We should ask about alcohol consumption and encourage a reduced intake if the person drinks excessively, as this can lower blood pressure and has broader health benefits. We should discourage excessive consumption of coffee and other caffeine-rich products. We should encourage people to keep their dietary sodium intake low, either by reducing salt or using substitutes, as this can also reduce blood pressure. However, salt substitutes containing potassium chloride should not be used by older people, people with diabetes, pregnant women, people with kidney disease, or those taking certain antihypertensive drugs such as ACE inhibitors or ARBs. In these groups, we should focus on reducing salt intake rather than using substitutes. Finally, we should offer advice and support to help people to stop smoking. Now let's look at when we should start antihypertensive drug treatment. We should offer antihypertensive drug treatment to adults of any age with persistent stage 2 hypertension. That is, a clinic blood pressure of 160/100 or higher, but less than 180/120, and subsequent daytime average on ambulatory monitoring or average on home blood pressure monitoring of 150/95 or higher. We should use clinical judgement for people with frailty or multimorbidity in order to minimize overtreatment and the risk of side effects. What about those with stage 1 hypertension, that is a clinic blood pressure ranging from 140/90 to 155/99, and the corresponding daytime average on ambulatory monitoring or average on home monitoring ranging from 135/85 to 149/94? Well, treatment here will depend on risk factors. For adults under 80 with persistent stage 1 hypertension, we should definitely start treatment if they have signs of target organ damage, established cardiovascular disease, renal disease, diabetes, or a 10-year cardiovascular risk of 10% or more. Again, we should use clinical judgment in people with frailty or multimorbidity. In other situations, NICE is less prescriptive and recommends to consider treatment, which means using our clinical judgment more flexibly. For example, in adults under 60 with stage 1 hypertension and a 10-year cardiovascular risk below 10%, we should still consider treatment, bearing in mind that a 10-year risk score may underestimate lifetime cardiovascular risk. Similarly, in adults over 80 with stage 1 hypertension, we should consider treatment if clinic blood pressure is above 150/90. And this distinction between offer and consider is important. It reflects the level of certainty in the evidence and reminds us that clinical judgment is crucial. Finally, for adults under 40, we should consider specialist referral for secondary courses and assessment of long-term risks and benefits of treatment. Now let's go through clinic blood pressure targets. For adults under 80, the general target is a clinic blood pressure below 140/90. This applies to people with hypertension with or without type 2 diabetes, and also to those with type 1 diabetes or CKD if the albumin-creatinine ratio is below 70. However, if the albumin-creatinine ratio is 70 or higher, the target is lower, below 130/80. For adults aged 80 and over, the general clinic blood pressure target is below 150/90. And although this may feel counterintuitive, this target also applies to people with type 1 or type 2 diabetes, regardless of albumin-creatinine ratio. In this age group, albumin-creatinine ratio only changes the target for people with CKD. NICE does not set lower blood pressure targets in people over 80 just because they have diabetes, as the evidence for lower blood pressure in this age group is limited. So, if they have CKD with an albumin-creatinine ratio below 70, the target blood pressure is below 140/90, and if the albumin-creatinine ratio is 70 or higher, the target is below 130/80. Now let's look at the monitoring in practice. We should use clinic blood pressure measurements to monitor response to treatment. We should check for postural hypotension in people with type 2 diabetes, symptoms of postural hypotension, or those who are aged 80 and over. If there is a significant postural drop or symptoms, we should base treatment target on standing blood pressure. We should also consider ambulatory or home monitoring in addition to clinic readings if there is a white coat effect or masked hypertension. For people who self-monitor, we should use home blood pressure monitoring, and we should remember that out-of-clinic readings are about 5 mm of mercury lower. So, in adults without relevant comorbidities under 80, the target blood pressure is below 140/90 in clinic, or below 135/85 at home. Over 80, the target is below 150/90 in clinic, or below 145/85 at home. We should use the same blood pressure targets regardless of whether the person has established cardiovascular disease. When type 2 diabetes is diagnosed, we should review blood pressure control and the medications used and make changes if the current treatment is not appropriate because of macrovascular complications or metabolic problems. Finally, we should give an annual review for all adults with hypertension. So that is it, a review of a section of the NICE guideline on hypertension. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for listening, and goodbye.